Hello, we're going to discuss Chapter 4, the health record content and documentation. Documentation is very important when it comes to healthcare findings, interventions, responses to treatment, basically a business record or a form of communication among caregivers. It's the official legal document of everything that has happened to a patient. Kind of like if it isn't written, it never happened. The impact of poor documentation, there are poor outcomes. You're going to have issues with patient care, inaccuracy of diagnoses and procedure codes, then you're not going to bill it properly. Many different things happen. And it's a whole snowball effect, as they say. Documentation standards are created to show kind of consistency between codes, guidelines, regulations. All of that is put together once document standards are established. These standards also explain to healthcare providers what they should document in the health record specifically. So the standard is a set of principles, codes, beliefs, guidelines, and regulations that have been vetted. That means everybody has agreed and has accepted, either by an individual or a group of individuals. And that standard, whatever that standard is, controls health record documentation. Whether it's an electronic health record or paper-based health records, the same documentation standards apply. The difference, in both situations, there are templates that are established that guide you to complete certain information. The standards have grown and are more complicated these days because it is driven by patient quality care, what you're going to get reimbursed, but it's a balance because you don't want to create things for higher reimbursement that never really happened. That leads you into prevention of fraud and abuse. So you may hear on the news a lot of physicians who are utilizing the patients that they see for creating more visits that then goes to insurance and making up visits that don't exist in order to gain more money. That would be considered fraud and abuse. Documentation standards vary based on the type of health record there is. So an ER record versus an inpatient record has different standards and requirements. Again, multiple sources are coming from creating those documentation standards. You've got insurance companies, government regulatory agencies, you've got licensing boards, accrediting bodies, and then that hospital's policies and procedures or medical staff bylaws. All of those affect what these standards are. Ultimately, the goal is to have a complete health record that accurately reflects what happened to that patient. And if you have complete, accurate information, the appropriate reimbursement will follow through accurate code capture. I mentioned medical staff bylaws. Basically, at every hospital, there's the medical staff, all the physicians. They have bylaws that are created when a hospital is formed and are voted on and agreed to by all the medical staff to follow. And it's approved by the healthcare organization's board of directors as well. And it's typically used to enforce quality of care. and there may be some financial ramifications if you don't follow that. So a long time ago, and I don't know if this is still practiced today, but if a physician did not complete uh, their records in a timely fashion within 30 days, they would be warned with a letter or a phone call. And after so many warnings, they would either get penalized financially, their paycheck was withheld, or they would lose admitting privileges or operating privileges. So again, those are all driven by the medical staff bylaws. These medical staff bylaws are required by licensure organizations like Medicare, Medicaid, accreditation organizations like Joint Commission, and federal and state regulatory agencies as well, like IDPH, Illinois Department of Public Health. Each organization has the flexibility to mandate the content, some of it. A lot of it is driven by all of these organizations, and it will slightly vary from organization from one to another. So like I said, in the example of penalties, I gave you 3 different examples of penalties when not completing medical records in a timely fashion. That would be an example of how it would vary from one institution into another. Physicians and non-physician providers, basically who have privileges to practice medicine, are part of the medical staff. They may or may not be employed by the healthcare organization, and they are subject to medical staff bylaws. Medical staff privileges are specific services or procedures that person, that physician, is qualified to perform and has been vetted in that particular healthcare organization. So at any given time, all the supervising nurses and all the units in a hospital will know what physician has what right when admitting or performing a procedure, because they get vetted by the medical staff office. So accreditation is a voluntary process, which is a key word. There are periodical evaluations against that pre-established criteria. So there is what's known like in Joint Commission, pre-established written criteria called information management criteria, in which every healthcare organization would need to follow to get accredited by that organization. And what's tracked is the measure of compliance of those standards. So an example would be a history and physical needs to be dictated within 24 hours prior to a procedure. Or if one was dictated or on file within the last 30 days of a procedure, can be accepted. So that's a standard that is governed by the accreditation agency, and compliance with that is to say, yeah, 99% of the time or 100% of the time when a patient went into a procedure, they had a history and physical on file meeting that criteria. Otherwise, they shouldn't be having a surgery. A healthcare organization that are accredited by an approved accreditation organization are exempt from routine state survey agencies. So, Medicare, Medicaid, no. Joint Commission could be vetted or accredited by Medicare, Medicaid. Therefore, if a hospital is accredited by Joint Commission, it automatically is accredited by CMS, the Center for Medicare, Medicaid Services. Once you go through that CMS, the Center of Medicare Medicaid Services review to obtain this deemed status, you have to go through it. And once you obviously have that accreditation, it's again voluntary to be Joint Commission accredited, but by CMS, you have to go through it if you're going to be taking Medicare Medicaid patients. So I've already used Joint Commission as an example. It is one of the most popular, widely used healthcare organizations that accredits healthcare organizations. They do various surveys. They're clinical and operational, and they also provide education when it comes to trying to achieve compliance. Here is a list of various departments, agencies that Joint Commission provides accreditation for, organizations, I guess is the better word. It's not uncommon for a hospital to be accredited by Joint Commission, but let's say the pathology department accredited by another organization other than Joint Commission. So keep that in mind. There's other accreditation organizations. So the Commission, so Healthcare Facilities Accreditation Program, Commission on Accreditation of Rehab Facilities, also known as CARF, C-A-R-F. You have HFAP was Healthcare Facilities Accreditation Program, and AAAH, Accreditation Association for Ambulatory Healthcare. So ambulatory, rehab, they're all, again, other organizations that accredit. There are state statutes that, again, talks about state level legislation that is signed into law by the state governor that could address documentation requirements for specific records. So an example of a state statute could be that all healthcare run facilities, all state run healthcare facilities, for instance, Stroger, aka Cook County, has to maintain their records either in microfilm or in paper format. And that is the only acceptable method. So when we are talking about document imaging or electronic health record, it doesn't allow, the state legislation does not allow to do that. It doesn't mean it doesn't allow to do that. It just means you can scan the paper medical records, but you better still have the paper medical records as the legal official document. That's an example of how a state statute would govern and affect documentation or record retention. The legal health record are basically documents and data elements that a healthcare provider may include to a legally permissible request for patient information. Legal health record is defined differently from institution to institution. There is a lot of things that are the same but can be different. For example, a legal accepting medical records, copies of medical records, whether electronic or paper, from another institution, whether you incorporate that as part of the legal health record or not in your institution. So let's say Northwestern is receiving records from University of Chicago. Northwestern can accept these records, can review them, treat the patient appropriately, but may have a policy and procedure never to incorporate those as part of their legal health record. Therefore, whenever subpoenaed, requested, they would not release University of Chicago records, even though they utilize them for treatment of care. So there are policies and procedures that definitely have to be established in defining what your institution's legal health record is. General documentation guidelines should apply to all categories of health records. Again, there should be policies and procedures that you can point to, and definitely help you find records or data elements where they exist. Only individuals authorized by the organization's policies should be allowed to enter documentation in the health record. So everybody that works in a hospital does not have the authorization to document. So residents, for instance, depending on the institution, may document in the record, but may have to be required to have a physician sign off and date after reviewing what the resident posted. Others give the authority to residents to document. So it all depends on the medical staff guidelines, policies, and procedures, whether that could happen. Health record entries, especially today in the electronic environment, should always be documented at the time of service, that they are prescribed or utilized. So when medication is given to a patient, it should not be documented 5 hours later that Tylenol was given at 3 p.m. when in fact, and documented at 11 p.m. when Tylenol is given to a patient. It should be documented at the time of service. All authors of entry should clearly be defined in the record. So in the paper world, the physician's scribble was really always questionable. Now, with the electronic world, it is very clearly defined who the author is. Abbreviations and symbols should only be utilized that are approved by the medical staff and the medical staff bylaws. So you can't be creating rules about abbreviations. So BTW does not exist in the healthcare world, but in texting, BTW means by the way, or WNL is a common abbreviation that is utilized in the healthcare and accepted in documentation, which means WNL within normal limits. You're very familiar with prescription abbreviations that are acceptable, BID or TID, meaning twice daily or 3 times daily. All entries in the health record should be permanent. You could do amendments, you could do changes, but it will never be deleted. Entries in the electronic world now are very much so legible. They may not always be complete. They are always dated and timed. The author is always identified. There's no anonymous posts basically, and anything that is dictated is authenticated in written or electronic form. What authentication means is that there's some type of digital or written signature, initials, something that identifies who authored that post. CMS basically requires controls to prevent any changes from being made after they've been authenticated. So if a resident does documentation, and according to the staff bylaws, a physician needs to review it and sign off on it, that resident can't go back after that signature has been placed by the physician, the attending physician. They cannot go back and alter anything. Auto-authentication means when a physician or another healthcare provider authenticates or signs off without reviewing. When the EHR first came about, and there was transcribed documents that needed to be reviewed by the physicians, physicians tended to open up these electronic documents and scroll down to the bottom without reviewing and just hitting a button to auto authenticate. So now the systems kind of force you to peruse, just kind of like when you're clicking off some legal documents electronically. Sometimes it forces you, you have to scroll down. So even though technically you're not reading, it kind of slows down the process that maybe you might want to consider reading it before signing off on it. And that's what auto authentication kind of prevents or minimizes. The health record consists of two types, regardless of the setting. So that means there's a clinical component to a health record, or AKA medical record, and there's an administrative component to it. So just like it kind of leads you to believe, the clinical is where you're actually doing medical care documentation. Administrative are those business office things that you have to capture a driver's license, you have to capture insurance information. So one is medical and the other one is more operational, if you want to consider it that way. You have to have a medical record for each person. The content will vary from setting to setting, and it will always have these two components, the clinical and administrative data. So let's break down some of the common types of records. You've got an inpatient record, where the patient stays overnight, one or multiple nights. They could be a medical or a surgical, and it is the most complex health record. And if you're coding records, you will be considered the most well-versed if you're able to do an inpatient record. In an inpatient record, you've got the medical history, which I think you're familiar with, what's going on with the patient, the past and the present, why are they here, what are they complaining about. It will contain a physical exam. It will also have the diagnostic or therapeutic procedure orders, so a physician's order or some kind of a standing order. And this, mind you, is all so far in the clinical aspect of the record. There's going to be some kind of clinical observation, so like a progress note. And then there's going to be a care plan, so what's happening, how is the patient being treated. If the patient passed away, there's going to be an autopsy report. There's going to be vital signs that we'll capture. Flow charts, meaning they're constantly getting input or output of urine and water. It's going to be capturing your blood pressure, an EKG, any kind of diagnostic therapeutic procedure reports will be in here, those types of tests. If there was an operation, there would be an anesthesia report, then the operative report. There's a recovery room report. If there's any specimens removed, there would be a pathology report. And if after this procedure there needs to be a consultation because of the results or what was found, there would be a consultation report. Once a patient is discharged, there would be basically kind of an overview of what happened during this patient's day. So it's called a discharge summary. This is not required for hospitalization less than 48 hours on an uncomplicated delivery or a newborn. There's going to be patient instructions, and if the patient's being transferred from a hospital to, let's say, a rehab facility, those transfer records will be going with them as well. Now, on the administrative side of that inpatient record, there's going to be the registration information, which is partially the demographics of that patient, any kind of insurance information, consent forms, all of that. That's part of the administrative. There are special health records that that have unique requirements because of those types of services. So, for instance, an obstetric or a newborn health record, in addition to what is typically for an inpatient record, they also, on top of that, have prenatal and labor and delivery records. Or if it's a newborn, they have an APGAR score listed as well. And again, some ambulatory health records, which again are kind of like outpatient visits, they're going to have demographics and a problem list. Surgery, ambulatory surgery, is very similar to a surgical health record, but there's some follow-up post-op surgery, and this is kind of like those, like a colonoscopy. You're going in, it's outpatient, you're not spending the night, they're going to do a procedure, they might remove tissues, and then you're out of there in a couple of hours. Ancillary departments are just basically some tests and procedures that are being done. You've got the physician office record, which is all about preventative care or minor illnesses and injuries. Long-term care, that's ongoing assessments with the care plan. Long-term care patients are called residents, and there is a resident assessment instrument that is used, an RAI, and that is basically a multidisciplinary document that follows the patient's care on a long-term basis. And there is a very specific criteria of what data is being captured for and released for long-term care. There's rehabilitation records that is mandated, again, with that resident assessment instrument. There's a 5-day assessment. There's an interim payment assessment that is optional, and a discharge assessment. So after being seen in rehab for 5 days, you have to provide certain documentation. The middle one is optional, and then when the patient gets discharged from a rehab facility, there's a discharge assessment that is provided. Behavioral health includes very similar content, and you also have family and caregiver information that is documented within the record. Home health, there is a treatment plan, an assessment, problem list, treatment goals, interventions, and outcomes that have to be listed. So if you've got home health coming to you and you're having physical therapy, you're going to have that problem list, a treatment plan, what the goals are that a person needs to be walking by week 5, and then of course what the outcomes are. There are federal and state initiatives always on documentation, and it is driven by focusing on the quality of care or value-based care. And there's a lot of reimbursement that is changing in today's environment that is requiring reimbursement is happening because of quality of care. So it's being pushed on how healthy a patient is for a physician rather than for each service that is provided. So if a physician is seeing a diabetic patient, if this diabetic patient is constantly being hospitalized or coming to the physician's office, they are not going to get reimbursed, let's say maybe at 100%, because it seems that this physician is not taking care of this patient. If the patient is considered diabetic and rarely is seen by the physician, rarely is seen by a hospital, that it's to basically potentially assume that they're getting the care that they need, that they're taking the medication that they need, they're getting the education that they need. Therefore, the physician proactively is going to be making money because they have a healthy patient, if that makes sense. In a paper healthcare environment, the way the format was kept was pretty important. And like I said, there's still paper out there, it's just minimal these days. So source-oriented health record documentation is just talking about who's documenting, and that section of the record is based on a physician or based on a therapist, a source-oriented health record. Universal chart order, everybody is documenting in that record. Integrated, everybody is, but it's kind of like separated. And then you've got a problem-oriented medical record, or a SOAP note, which is common, and you will still hear SOAP note today, where it's talking about a subjective, objective assessment and plan. So you gather subjectively from the patient what they are complaining about. You do objective analysis, like taking blood pressure, doing an evaluation or an exam, and capturing objective information. You do an assessment, so you look at the subjective and objective, and you come up with what you think is going on, or what you're seeing, and then you, through this assessment, figure out, oh, it's this, now I have a plan. And you can have multiple problems listed and multiple plans listed as well. In the electronic health record, it's more about point of care documentation and capturing it in real time. So in the example previously, when you're giving a Tylenol at 3 o'clock in the afternoon, you better be capturing documentation that you've given that Tylenol to that patient at 3:01 and signing off on it. Web-based document imaging, I personally would not call it web-based, it's just document imaging. So that process is about capturing or taking a picture, digitizing a piece of paper, integrating it in a software system, storing it permanently in the software system, retrieving whenever needed. So basically, you take a picture of that medical record, and if you add anything to it, there's going to be controls for versioning, access is going to be limited or tracked, and that paper goes away, and now you've got an electronic record. It's not the true electronic health record because it wasn't directly entered into the EHR, but it is one step closer. So the role of healthcare professionals, physicians definitely have to monitor care of their patients and make sure that they document everything and what assumptions that they're doing so that coders and billers can code properly, bill properly, and the hospital or the physician's office get reimbursed appropriately. Because if you didn't document it, it didn't happen, even if it's obvious. And when I mean obvious, it's an obvious assumption. Nurses are driven, all of the documentation requirements are driven by licensing and regulatory requirements as well as policies and procedures of that facility. Allied health professionals also follow various regulatory agencies, and they document the treatment and sometimes the patient's responses. HIM and documentation plays a vital role when it comes to overall governance of health record information. So what is being captured? How long is it being retained? Who has access to it? And then how it's used when we're talking about encoding, billing, and any other HIM functions and research. So we play a critical role to make sure that information is documented appropriately and analyzed. So this concludes chapter 4.